Okay, good evening, everybody. My name is Christian Vincent. I'm in FEOPS Clinical Director. It's really my pleasure to welcome you all in this education session. This year, FEOPS is engaged to be present in an education program of the PCR Valves 2020 with sessions focused on Meet the Expert on Digital Heart. Today, this afternoon, the session will be focused on the learning of the predictive value of virtual implants in complex TAVI using Evolut device into TAVI interventions. The faculty will be Dr. Matti Adam, that I'm very honored to welcome today. He is from the University of Cologne in Germany. You know, it will be a Zoom session, 30 minutes, including discussion. We would like to have as much as possible to have interaction, so do not hesitate to ask questions. You will have a chat box at the bottom of your screen. If you click there, you can ask any questions, and I will be the relay between you and Dr. Adam for those questions, and we will answer directly on this call. The other way of interactivity during the call, we will have a quick polls, a survey to ask you a couple of questions regarding your personal opinion about some decision to make. I wish you all a very nice presentation, but before that, I would like to show you the learning objective of this session. In this Meet the Expert session at the PCR Valves, you will benefit from a unique occasion to comment, to question, and to exchange also with your peers. At the end of the module, you will be able to identify challenges into complex TAVI interventions, such as BAV cases, when you use Evolut in your practice. You will also understand the role of patient-specific virtual implants in different morphologies, also to explore the different functionalities you can have on the FEOPS Heart Guide preoperative planning tool. And last but not least, it's a nice opportunity for all of us to participate in a case-based discussion that highlight the clinical value of advanced preoperative planning. So, Dr. Matti Adam, so I welcome you, and I wish to all of you a great sessions. Thank you. You need to unmute you, Matti. Matti, you are still in mute. You are still on the mute. Yeah, no, now it should be okay. I'm not hearing you. Please unmute. Can you unmute him?
Does he have like earphones in?
Matti, we cannot hear you. We cannot hear you, Matti. Something. Matti? Matti, there is something wrong. We cannot hear you. No, now you're mute. Unmute.
Let's try a different microphone. Is that better?
That's cool. Now we can hear you well. Okay.
Good. Magic of technique. It worked fine just 5 minutes ago. Sorry, Christian. So thank you for the warm and brief introduction and very hearty welcome from Cologne. So as Christian already mentioned, I think this is going to be a Meet the Expert, and unfortunately we cannot do this in person today. So I will just want to encourage you that please, if you have any questions, don't hesitate to contact Christian, and then we're going to discuss this as we go. So what am I going to show you today? So as Christian mentioned, we want to enlighten a little bit how we can use FEOPS, patient-specific computer simulation, in cases where you use a Medtronic Evolut valve. For me, that makes sense in different conditions, and I just wanted to elaborate a little bit on when and why I'm using this technique. So obviously we were talking about complex and challenging interventions, and let's see how this can help us. I mean, a couple of words on the technology itself, but first of all, I wanted to ask you, before we start, a little quick poll. In cases that are more complex than your standard TAVI case, for example, bicuspid case or very heavy calcifications, when you use an Evolut valve, I mean, based on your standard preoperative CT data, how comfortable are you in making a decision on sizing and positioning for an Evolut valve based on your CT? 100% sure, I'm comfortable, I'm not comfortable, or you're the person that says, you know, I don't ever use this valve. I mean, then you're in a session that, you know, you might not actually learn how to implant an Evolut, but maybe we can show you advantages and disadvantages of this valve. But I personally use a different valve. Maybe that's your opinion. So let's see.
Okay, the audience is voting.
Great. I'm really looking forward to this. I mean, I'm excited to see the results.
Okay.
All right. So from what I see here, nobody is 100% sure. At least over a third of all of you is comfortable in using the CT data that you already have, and some of you are not comfortable. And I think that this is actually what I would pick as well. I'm very comfortable in standard cases, but when it comes to complex and challenging anatomies, I'm not 100% comfortable. So I would say I'm not comfortable as well. Okay, so going from that, I just wanted to mention again, okay, in normal anatomies, what are we doing, right? We are using CT data, and we are right inside the guidelines there. The European Society of Cardiology guidelines are MSCT is the preferred imaging tool to assess the anatomy and the dimensions of your aortic valve. And I would strongly recommend, but I don't think there's anyone who would disagree on that you never do a TAVI without a CT. And what we're measuring is the annulus, we're measuring the LVOT, the sinus of Valsalva, and the coronary height. And with all that, we can integrate this information. And I think at some point you can even use your projections and calculate everything. So it makes you feel very comfortable, in my opinion. And then you say, okay, I'm going to use this and that valve, and the result is somehow predictable. But again, you all know there are not only the normal day-to-day cases, there are also bicuspid cases. And depending on where you are, it might actually be more common. For example, in China, it's over 10%. And you all know that in the European countries, this is a little bit less. For example, in Germany, we have 2.7% of bicuspid valves. And usually these are not type 0 valves where you have no RAFI and two normally developed cusp and commissures. But you have the type 1 bicuspid aortic valve with the most common type BLR, where the RAF is between the left and the right coronary cusp, right? And referring to what I just said, I mean, for tricuspid, we know how to measure. We just go to the bottom point of the cusp, and then we measure the annulus, and then we basically know what valve we got to put in. But for bicuspid, it's a bit more complex. We have the annulus measurements. We have the intercomer distance at 4 millimeters above the annulus. Then we measure the area there. We put an ellipse in. We think of how the valve will actually develop, and you try to get a feeling of that. You look at the calcium, at the distribution. You look how big the RAF is calcified and how long it is, and then from all of that, you're trying to consider what you're going to do with this patient, right? And maybe we have something that can help us. And obviously, we're talking about FEOPS HeartCat, and I would recommend that you stay with me, and then we'll see if you like this technology as I am doing. So how does this actually work? So you send your CT data to FEOPS, you upload your anonymous CT scan, and then FEOPS is creating a reconstruction of the aortic root, and this is called the segmentation phase. And then if you have a good resolution and a good CT quality, then you will actually see how the calcium is distributed, and you can easily look around and understand the valve morphology itself. And then there comes the simulation phase, where the valve is actually simulated in the tissue. So everything is annotated with like anatomical values and with structural values from the valve. And then it's not only a layover, it's really a simulation. And then in the end, you're gonna have a look at how much PVL is predicted, how high might the pacemaker rate be. I'm going to show you this in a second, and how is the skirt apposition, okay? And this is all a web-based tool. But is this all magic in a box, or does this actually work? And for example, in these complex anatomies that we're talking about in BAV cases, Dowling et al. Published in Circ Cardiovascular Imaging a comparison between the simulation results and the postoperative MSCT scans. And as you can see, for area, minimal diameter, maximal diameter, and the perimeter, the correlations of the predicted value and the postoperative MSCT value were pretty close together. So a very strong correlation, indicating that, I mean, the simulation might not be perfect, but in the end, it worked very well. So let's assume you say, okay, now you get me interested. I'm going to sign up for this. So what's happening actually? So this is the web interface that you'll see. And again, you have your CT data that you, with your anonymous patient information. And then this is actually how it looks like. You will have, after 24 to 48 hours, the simulation will be ready. And then you can freely look around and show how the valve itself looks, how the calcification pattern is, how the frame deformation will be. And then you see in the drop-down menu there, you can actually choose between the valve sizes that might be interesting in this case. And also in the beginning, you can also pick, hey, do I want to simulate an Evolut case, or do I want to simulate different, for example, Lotus or Symetis, right, accurate. And when you have looked through all that, you can also, with the drop-down menu on the left-hand side, you can also look for contact pressure, for example, and we're going to talk about this a little bit more, referring to the different implantation heights that you wanted to simulate. And also you can look at skirt apposition. Here, yellow is good, red means there's not going to be a good apposition, so there's more than 1 millimeter skirt. There's a little gap between the skirt and the calcium, for example. And then also there's going to be some predicted paravalvular leakage, and you'll have an absolute value, for example, here on the right-hand side, 13 milliliters per second for that implantation height and that size of the valve. So in the end, you're going to have objective, very clear data points, and some subjective, how does it look, how is the frame actually deformed, data that you can look into. So that said, let's start with our first case. Okay, so I brought you a case of a very ill patient. His ejection fraction was 35%. He was on constant oxygen support. He was highly symptomatic. And also he had pretty high gradients. So mean was above 50 millimeters mercury. Clearly, this was a severe aortic stenosis. The first look I had at the echo and at the CT showed that it's actually a bicuspid valve, as you can appreciate here. And for me, I considered that a type 0 from looking at the echo. But as you can see in the simulation, for example, down here, there is actually an LR REFI. So for me, putting that in the simulation made it easier to understand the anatomy of that valve. Of course, it was very heavily calcified. And so my question was, if I put an Evolut valve in this patient because he needed help, I couldn't treat him conservatively, and I couldn't refer him to surgery, so I had to do something. What's going to be the PVL in this patient? How's the position? How's the frame deformation? And what kind of result do I get if I treat this patient with an Evolut? So we decided to run with a patient-specific computer simulation here. And these are screenshots from the web tool that we just showed you. And so the first line is a high implantation height, which is usually aiming for 3 millimeters. And then the second one is a low implantation for an Evolut 29 Pro valve, okay? And you see that what you might have seen in other publications as well, that in bicuspid valves, the self-expanding valves will not form a full circuit. They will just adapt to anatomy. This might be an advantage. And if you have a supraannular valve, the function might still be good. So, but still, this is pretty heavy frame deformation. So when I saw this at first, I was pretty impressed. And that means that the simulation at least shows me that I will not break up this LR calcified RAFI, right? And then again, we talked about this a second earlier. This is skirt deposition, and you can see everything that's yellow is fine. But then what's red indicates that you're more than 1 millimeters with a gap here. So here, this looks critical, right? And this directly refers to a PVL, which is quantified with 17 milliliters per second or 30 milliliters per second, depending on the implant height. And from our previous studies, we know that 16 milliliters per second in this simulation is actually something that you have non or mild PVL on the one hand side, or when you're above, it might actually be more than mild, so moderate or severe PVL. And then we talked about, I mentioned contact pressure. So what you see here is that 0.4 megapascals will be indicated as a red dot, and everything above still is red. So this means that in these areas, you'll have pressure of the valve on the tissue. You can see this is the case up here above the STJ because of the design of the Evolut valve, and also down here. And this region is basically the region inferior of the membranous septum, so the region where you would suggest that your AV conduction system is. And if it's more than 14%, as indicated here, there is data, or there might be indications that if it's above 14%, that your pacemaker rate goes actually up. So you might have conduction abnormalities. So integrating all this, that meant for me, okay, this is not gonna be a great result, okay? So either I implant high and I have a 17 milliliter per second PVL, which is probably moderate, and still a pretty significant pacemaker rate. And if I go more deep or deeper with the implantation, I might actually lose some PVL, but still gonna be moderate PVL maybe, and just increase, almost double my pacemaker rate, okay? In the end, we decided to go for that procedure anyways, because we knew that the patient will not benefit from anything else, but we knew that we're not gonna have the perfect result, and that was okay for this patient in this situation, okay? And as this is a Meet the Experts, I just show you exactly what our angio data looked like. So this is exactly the patient, and I show you I try to put the simulation view on the left and the right-hand side exactly as the implantation angle that we used. And you can see that exactly what was predicted did happen, right? We have a moderate PVL here in the region of in this projection, left coronary artery. And this is definitely moderate, and the valve actually looks almost as simulated. So we decided to leave it that way for this patient because we didn't want to go further with more dilatations, and actually harm the patient. The patient is fine now, so he improved in that process, but of course, this is not the best result that we ever implanted, okay? Having showed you that, let's go to the second case. Again, this is a bicuspid case, and then also this patient was pretty severely diseased, had an EF of 29%, so at least moderately impaired LV function, had also a very high operative risk and was highly symptomatic. And even you might not appreciate that in the first view, but if you integrate that with echo, this was also a bicuspid valve as well. And this was the not so common type R right non-coronary cusps with a shorter RAFI here, but still very heavily calcified. Also, again, it helped me to understand how this actually looked in the patient when we uploaded this for patient-specific computer simulation. As you can see, this big chunk of calcification down here in the RN region. Okay, so what did simulation result show us in this patient? And here we decided Let me go one slide back. You see, this is a 27.2 perimeter derived diameter. So in terms of an Evolut, this would actually be a 34, okay? So we decided, okay, let's simulate 29 and 34 because this was a very tiny lady. And also if you have bicuspid valves, you might consider, depending on the calcification, you might consider if you want to downsize a little bit, okay? So we simulated 29 and a 34. And again, we've looked at the high and the medium implant. We basically don't look at low implants because this usually gives you no advantage. As you can see here, the 34 had clearly the best results. The PVL rates dropped when we're switching from 29 to 34, and we had a very good skirt apposition. So for us, that meant, okay, if we can get a 34 somewhere between high and medium implanted, then we might actually have a good result in this patient. So we went for the procedure. And again, I tried to align everything in terms of angulation. And as you can see here, again, the simulation basically indicated us how the procedure went. I mean, we came out at a very, let's say, optimal implantation height, probably more high than low, but still we had not a lot of PVL, and the frame almost was completely expanded, which underlines that maybe the length and the calcification of the raphe is something that we want to look at. But integrating all these complex CT measurements and considerations, this actually helped us a lot in this case. And I brought you a third case, which is a bit different because I thought, okay, I've shown you now one very good bicuspid valve case, and I showed you one that might have left a little room for improvement. And I thought I'd bring you something else for case 3. And the challenge here was that we had a very huge calcification of the LVOT, reaching from the annulus down to the LVOT to the mitral valve. And I mean, just look at this thing, right? It's a huge chunk of calcium. And when I first saw the CT, I wasn't so sure what to do with this patient. But again, I mean, she was highly symptomatic, had chest radiation, lung fibrosis, very severe gradients. And I mean, there was a need that we really needed to treat her. Okay, so the questions for me were, how much PVL am I going to get in this patient, right? And is this actually dangerous to perform this procedure? So how much pressure do I have on certain areas of that anatomy? And then we decided again to run for patient-specific computer simulation using FIOPS HeartGuide. And I'm going to show you in a second what the simulation showed us. So this was a 21.6 perimeter derived diameter. So for an Evolut, this would usually be a 26. But we thought maybe oversizing a little bit might help us reducing the PVL. So we simulated 26 and a 29. And what you can appreciate here again, there are pictures from high implant and medium implant for the 26 and the 29. And what you can see here is that the 26 actually had pretty good results already. So we didn't need to oversize that immensely for the 29 Evolut Pro valve, okay? So the 26 Evolut Pro showed that we have almost, or let's say, only slight PVL or mild PVL predicted if we implant high or medium, basically the same, around 5 milliliters per second. But if we come up, if like the deeper we implant, of course, this is nothing new to you, but the deeper we go, the higher our pacemaker risk will be, because we have more than 14% of these red dots in that region of interest. We had 24% there. So we thought, okay, if we go with the 26 Evolut Pro, we will have okay PVL, probably mild. And if we go not so deep, we might actually come off without a pacemaker. So that's exactly what we did. And again, try to put yourself in the position to understand that from the angulation view. And to my defense, the patient had bad renal function. Okay, so I know this is not the most contrast agent you've ever seen in an angiography, but well, I didn't know that I would use this view for a presentation. Okay, so I hope you understand that. But what you see here is that the valve exactly looked like the valve in the simulation, and we had absolutely no PVL. I mean, in echo, and then you just have to believe me, in echo there was a mild PVL. So it came basically out the way it was predicted, and implantation height was okay, and we came off without a pacemaker. So for us, in this patient, it enabled us to have better confidence in using a 26 valve, and also to expect better results than I would have thought from the CT scan alone. And in this case, I wanted to show you those two pictures so that you can appreciate what actually these the skirt overlap or this skirt apposition tells you. As you can see here, there is this huge chunk of calcification, right? And you can see that the skirt of the Evolut valve basically covers all this, and you have a region where you have no good skirt apposition, but you have a lot of apposition up there, which means there will be no PVL. And this is the information you only get from that simulation, okay? So having shown you the three cases, and please answer honestly, because sometimes I feel it's very useful for me, but I just want to see if that's the case for other people out there. I would try to ask you the same question. So how comfortable are you in making a decision on sizing and positioning for an Evolut valve based on standard preoperative CT data and FIOPS heart guide in those patients with challenging anatomies, for example, BAV cases? Okay, so would you feel more or same comfortable or 100% sure, or would you now even more than before use a different valve if you have the simulation results? So please vote now.
People are voting. Okay. Okay.
Ha. All right. So, I mean, thank you for showing me that I'm not the only person who's actually using this technique or trying to use this technique to understand better and getting more comfortable in implanting this kind of valve. I mean, you can use different valves as well, but for this valve, I have the most experience. So this is exactly, I'm just going to close this. This is exactly what I wanted to show you. There are interventions in TAVI that can be challenging, for example, bicuspid and heavy calcifications. And for me, adding the simulation might help me understand the anatomy, the position of the valve, what valve size I'm going to use, and what I can expect from the procedure. It's definitely nothing you want to do for your standard case, to be entirely honest, because it's just too much of a process for something that you understand so good already. But in these complex cases, it's definitely another trick up your sleeve. So thanks for listening. I hope that there pop up some questions in the chats. If not, I'm still around, so contact me anytime, and also shoot me an email if you like. So let's see if there's something that we can discuss. Thank you very much.
Thank you so much, Dr. Adam. So so there is no question. It looked like you are extremely clear in your presentation, and I think that the three cases were extremely clear. And indeed, it's really matching the idea that we need to focus on complex case, complex anatomies, whatever it's a high calcification, BAV, or whatsoever. You demonstrate a lot of very interesting cases. I really want to thank you for that. I thank you for all the audience to be there with us tonight. You see that we have an education room at Valves, PCR Valves 2020. For today, we don't have any more sessions, but tomorrow morning at 9 o'clock, we start again with other sessions, starting one at 9 with the LEA occlusion. So I hope I will still see a lot of people. You can always meet us if you go to the main page of the PCR valves. You see the training, you click there and you see FEOPS, and not only you see the sessions for tomorrow, but also a lot of resources. And as Matti mentioned in his presentation, if other questions are coming, we will always relay those questions to Dr. Adam tomorrow or afterwards. There is a button where you can contact us. Additional questions can come in the coming days, and we will be more than happy to answer those questions. By saying that, again, Dr. Adam, thank you so much for your really nice presentation. And I wish you a very good continuation into the PCR valves this year. Thank you. Good evening. Bye.